In today's episode, we're going over a case study of a lateral ankle sprain in a trail runner. Let's go. So I have a freebie for you today. It is an evidence-based guide to lateral ankle sprains, a cheat sheet. We go over a lot of really good stuff that's going to help you out with today's lesson, like the prevalence, the history, the prognosis, predisposing factors, mechanisms of injury, anatomy, diagnosis, differential diagnosis, treatment, return to work and sport, and injury prevention for lateral ankle sprain injuries. It is packed with info, guys. 100% free. Going to put a link in the show notes. Definitely check that out. Let's get moving. You are watching part 2 of a 3-part series. If you missed part 1, I'll leave a link in the show notes. Check it out before you continue. So how do we go about modifying training, right? I just said previously they want to maintain our training and physical activity as much as humanly possible. But if we do too much, we can obviously make this thing worse, set ourselves back, right? So what do I tell my patients from an exercise standpoint? I basically tell them that anything in the gym, right, or even with running that feels very tolerable to you and there's minimal pain associated with the activity, it's probably okay. With the caveat being that after you do that activity, the following day and that night after the activity, you don't get incredibly swollen. You don't start losing range of motion. You don't create a ton more pain, okay? Because if we're doing activities that feel decent in the moment, but the next day you feel terrible, those are probably going to be too much, okay? And like I said, I don't want to stop exercise because we know there's a myriad of health benefits. And if we have an individual that's used to regularly exercising and we stop them from regularly exercising, we know there's a whole host of problems associated with being sedentary. We want to avoid that as best as possible. The other piece is that she had a prior ACL reconstruction surgery. She's about 2 years out, but she's had a history of just a heck of a time getting her quad strength back, trying to get this thing to stop hurting. And she knows that when she stops exercising, her pain tends to creep back on. So really want to make sure that we continue exercising so we allow that knee to stay strong, not to become a problem again. Okay. And like I said, from an exercise standpoint, minimal pain is okay. Got to watch out for the next day. Let's make sure we don't have more pain, more soreness, more swelling, or reduced range of motion. I also tell my patients, like, hey, your ankle is going to be a little sore from exercise. That's okay. I think it's unreasonable to tell your patients, like, your pain should only hurt while you're doing it. And if it hurts the next day whatsoever, you did too much. I don't think that's really fair. To be honest, like, if you exercise a little bit, you get after it some, the next day, it's probably going to be a little bit sore, and that's okay. And if they get really sore and it's a little too much, we just back off, okay? The other piece is that we want these exercises to be tolerable with minimal pain, but we don't want to see a big limp, okay? So I sprained my ankle recently and I could run, but it looked god awful. It looked terrible. If I ran through that ankle sprain, I would have developed some weird issues, probably hurt something else just because I was running like an idiot because I didn't have any push off during running. So when I say it's okay to continue exercising, that's as long as you don't see a major compensation, right? If you're going to the gym and deadlifting and you're putting all of your weight on the uninjured side, that's obviously not good, okay? But otherwise, we want to keep training as much as we can. So how do we have to modify training for a patient initially? Well, for one, from a running perspective, we pretty much had to eliminate running, and she had already done that. She was having enough trouble walking, so she's like, I probably shouldn't run if I can't walk, and that makes sense, okay? However, she could tolerate walking, and she really wasn't doing any walking at this point. So I actually recommended a walking program. And she really just started with 10 to 15 minutes of walking at a slow pace. Make sure you're not limping. If you notice you start to limp because you're walking too fast, just slow it down, make things a little bit more symmetrical. And then over the course of time, we just ended up increasing the amount of walking to the point where she was walking about the same amount as she wanted to run. Okay. I know walking is not running. There's obviously more impact with running. But if we increase the volume of walking we can tolerate, I think that actually prepares you somewhat for running in the future, right? So we want to try to maintain our fitness as much as we can. We had to substitute walking for running, and we had to reduce the total volume of walking as well, okay? From a squatting and deadlifting perspective, we had her try a little bit of squatting. I think it was the first or second session, right? We weren't able to get to everything that first session. She didn't have any problems. She felt pretty good. Ankle felt good. I didn't see any major compensations. Like, yeah, keep squatting, keep deadlifting. Don't worry about those things. Try to push those as much as you normally would. Now, she had a lot of ankle pain, and the place to watch for most folks is the bottom position of a squat or deadlift when you require more ankle dorsiflexion. You may find that they don't like that position, so they compensate as a result, but she didn't. She looked great. So I'd say, keep on deadlifting and squatting. Don't even think you had an injury. Just keep on going, okay? From a single-legged strength perspective, she was already doing some of this prior. She was strength training twice per week. We had to modify these movements just a little bit. Like I said, she couldn't even balance on one leg. So something like a single-legged deadlift or single-legged squat was not going to happen. However, if we added a kickstand, so basically if we did a kickstand, single-legged deadlift, or a kickstand, single-legged squat, she could actually do the motion really well. And the only modification we had to do for these movements was to add the kickstand, slow things down a little bit, and reduce the weight slightly. But you can see that these movements are going to continue working towards her fitness goals, keep her healthy, and actually end up rehabbing her ankle just by continuing to be fit and healthy and working out in the gym. Next step, what did we do? We loaded her up. We worked on strength. And like I said, she was already doing the heavy lifting. I'm using quotations there because I think it's funny, right? She was already doing strength training 2 days per week. She was already doing some form of squat, deadlift, split squat, single-legged squat, and single-legged deadlifts. I had her continuing doing all of those motions. We just modified things slightly by reducing the speed, reducing the load, adding a kickstand, with also the additional feedback to try your best to maintain symmetry as much as you can during the movements. So when you're doing a split squat, let's have 50% of the weight in the front leg and the back leg. And when you switch sides, let's make sure it stays 50-50 and doesn't start a weird compensation pattern, right? On top of that, I like to add a well-rounded strengthening program for the ankle. So what does that mean? I want to try to strengthen all of the musculature around the ankle. That's going to be the calf, the tib anterior. We're going to work on single-legged balance tremendously. That's a huge issue in folks after they've had a lateral ankle sprain. So when you stretch your ATFL or tear ATFL, you damage the proprioception within the ankle. So basically knowing where your ankle is in space. A lot of folks will say they feel very unstable when they balance on one leg after an ankle sprain. This could be because they just basically stretched the ligament on the outside of the ankle, right? Which is obviously providing stability. But the other piece is that they feel like they can't stabilize the ankle because now they've lost that proprioception, right? They can't tell where the heck their ankle is in space. It's really hard to control motion down there. So we have to really hammer single-legged balance as part of the rehabilitation program. We also like to work on inversion and eversion, so really strengthening those muscles as well. That's a very important part of rehab after lateral ankle sprain. And then from a balance perspective, our exercises are basically going from an easy level to a harder level, right? And this is a topic for another day. I actually have a really good video about single leg balance exercises. I'll leave that link in the show notes so you guys can check it out a bit later. On top of strengthening the foot and ankle, I want to make sure we basically obviously train the entire body because that's important from a fitness perspective, but also try to tackle the hip. And this is interesting, and the literature is not robust. There's just a couple studies looking at this right now, but folks that had a prior lateral ankle sprain tend to have less lateral hip strength. So what that means is their hip abduction strength goes down after they've had a lateral ankle sprain injury. So we probably just want to be aware of that and make sure we strengthen it over the course of time to rebuild symmetry. The reason being is because if you have reduced lateral hip strength, it increases your risk of future injury by 2 times. Okay, this is in male soccer players, so it's probably not going to apply to every single population. However, this may be a problem and a reason why you have recurrences in the future. So I just make sure that we have lateral hip strengthening in the program. And maybe before you return your athletes back to sport, you just do a quick hip abduction manual muscle test, right? Use a handheld dynamometer, make sure their strength is pretty similar to side. I think in this study, the cutoff for increased risk was less than 33% of their body weight when they're pushing in a sideline hip abduction measured by isometric testing or handheld dynamometer. I'll leave a link in the show notes if you guys want to read through that study. This is not the time to look at that, but needless to say, we want to keep some sort of lateral hip strengthening in your ankle sprain patients program. How about mobility for the ankle? Now, this is an interesting one, right? So basically, when you sprain your ankle, you stretch the crap out of the ATFL or CFL, generally speaking, right? Now, when you stretch something a lot, it makes sense the hip becomes loose, or excuse me, the ankle becomes looser. We don't want to loosen it up even more, right? And I agree with that sentiment. It's just that most folks, after they've had a lateral ankle sprain, tend to get stiffer, okay? Particularly into dorsiflexion as well as plantar flexion. Now, this is purely an anecdote. What I tend to see in folks that have had, let's say, chronic ankle instability or recurrent sprains, they tend to have more inversion on the side that has the recurrent sprains, but they tend to lose dorsiflexion and plantar flexion. Now, why the heck is this? Well, I can't tell you that I know exactly why, but it appears that after you have a lateral ankle sprain injury, your body tries to heal that ligament by putting down scar tissue and some extra synovium. And what happens is that when you dorsiflex, the extra scar, the extra synovium gets a little bit stuck within the joint, and it can limit dorsiflexion as well as plantar flexion. The other interesting component is that folks, after they had a lateral ankle sprain, also have bony changes within the talus. So it's kind of crazy sounding, but the majority of folks after lateral ankle sprain will grow a little extra bone on the front of their talus, right? So the talus sliding underneath of the tib and fib or the medial and lateral malleolus is very important for ankle dorsiflexion. And now if there's extra bone in that area, it can reduce range of motion, cause symptoms of anterior impingement, which is that sensation of the ankle is kind of stuck in the front when you try to perform a ankle stretch into dorsiflexion, or some pain that's associated with it. So what ends up happening is these folks get their ankle stretched out, and then it gets stiff over the course of time in ankle plantar flexion as well as dorsiflexion. So early on, after you have an ankle sprain, do you want to protect the range of motion a little bit? Yes, but just keep in mind it's going to get stiff over the course of time. So I recommend early range of motion. Make sure we're trying to maintain range of motion left to right as much as possible. And as this thing starts stiffening down, which it tends to get stiffer, I would say around the 1 or 2 week mark, you got to make sure you're working on getting that range of motion back as much as possible. Okay. And lastly, we want to apply a plyometric program. Reason being, we want to get back to running. Running is a series of plyometrics left to right over and over again, thousands of repetitions. The way we start to get folks ready for that is we apply a plyometric program. So guys, if you like what you're learning about so far, then I want you to go and check out the Fitness Pain-Free Mini Course. So I made a mini course. It's absolutely free. That's the next logical step if you want to learn more from me. So in the course, we go over 5 lessons. That first lesson is how traditional schooling has failed us, right? So schooling is phenomenal from a physical therapy perspective, but doesn't really teach you how to work with high-level athletes in the fitness world, right? Doesn't always teach you how to do the lifts appropriately. Doesn't teach you about progressions and regressions of common lifts within the gym. Doesn't teach you how to program normally, how to write rehab programs, or how to write injury prevention programs for these folks. Next thing we go over, 7 reasons why people get hurt in the gym, 4 simple steps to getting your clients out of pain, how to build the career of your dreams and earn the respect of your community. It's all well and good if you know exactly how to work with folks within the gym. But if you can't get these folks through the door on a regular basis, then you're simply not going to be living the dream that you want to, because you can't get the patients through the door that you want to work with. Okay, so I'll show you how to do that. And lastly, we'll talk a little bit about the Fitness Pain-Free certification, right? So I'll leave a link in the show notes. I definitely recommend checking this out. Once you sign up for the Fitness Pain-Free Mini Course, you will be automatically placed in the waitlist for the Fitness Pain-Free certification. Now, the Fitness Pain-Free certification is the course, the certification that I wish I had as a new grad that fills in all the gaps in knowledge that you don't get in physical therapy school. So A, you'll gain complete confidence working with injuries in the strength and fitness world. You'll learn optimal technique for both health and performance from myself and some of the best coaches in the world. You'll master programming for rehabilitation and injury prevention. Have fun while earning a whole bunch of physical therapy and physical therapy assistant credits. You have 31.5 of those. You'll also gain NSCA credits as well as CrossFit credits if you need those. This is the equivalent of a university education in working with injuries in the weight room. I really believe that. I've been adding to this thing over the past 5 or 6 years. It's massive, a ton of phenomenal information. And lastly, the biggest goal is just to fill your day with the patients you love working with and building the respect and admiration of the communities you love working with. So I'll leave a link in the show notes. Sign up for the Fitness Pain-Free Mini Course. The certification is open 4 times per year for 1 week to enroll into. If you're on the wait list by signing up for the Fitness Pain-Free Mini Course, I'll alert you when that next enrollment period is open and you can get started. Let's get back to the show now. So what does that plyometric program look like, and when do we initiate this, right? So this is my own personal opinion, although it's going to vary based on the physical therapist that you talk to. I like to get people started on plyometrics as soon as they're well tolerated, okay? Now, we have a bunch of research that suggests that you should wait until someone has full range of motion, they have the majority of their strength back, the swelling is gone or most of it is gone, and pain is eliminated before you start plyometrics. However, I do find that folks can tolerate some sort of plyometric after they've had a lateral ankle sprain with a little bit of pain. I don't think I'm setting them back in any way by doing this. But to be honest, I don't think there are good set guidelines about when it's okay to apply plyometrics. But generally speaking, I get folks starting on them as soon as possible, right? As soon as they're well tolerated, we don't have major compensation when doing them. Why is that? Well, one, I want to try to maintain their ability to perform plyometrics as much as possible. If you just had an injury, right, and you're not able to do the activities that you want to do, you're going to slide backwards. So the longer you slide backwards, obviously, the harder it is to get back up again after you're able to return back to that activity. So if we can start these activities sooner, we maintain that sport or fitness quality more easily, right? I also find that if you introduce plyometrics at a low level, they're often tolerated pretty dang well with minimal to no symptoms, right? So in this patient, I tried some plyos day one, wasn't happening. She just did not feel A, confident, or B, wasn't able to tolerate them well enough to do them whatsoever. But to be honest, 1 week after doing some basic exercises, so on visit number 2, I saw her, let's say, on a Thursday, and then I saw her again on the following Thursday. She was actually able to tolerate a good deal of plyometric in the form of pogo jumps. So we just did a lot of pogo jumps, first kind of straight up and down, then side to side. We did some mogul, scissor, different types of jumps. I can leave a link in the show notes if you guys want to check out my favorite plyometrics I use for patients. But she tolerated that really well, right? And as you'll see over the course of time, we ended up progressing to running, I would say, 2 weeks after we introduced plyometrics, right? Some guidelines you can follow from a plyometric perspective with your patients. I generally like to start with double-legged exercise. Think about the difference between a double-legged pogo jump and then a single-legged pogo jump. I like to focus first on building capacity or tolerance. So we start with easy variations of plyometrics at a low volume, and then we increase the volume over the course of time, right? And as someone is starting to tolerate more and more, we start to introduce power last, okay? So it's volume and capacity first, and then intensity second. The other thing we focus on first is moving in the sagittal plane, and eventually moving more in the transverse plane as well as the frontal plane. When folks have a lateral ankle sprain, they're not good at handling forces within the frontal plane, so it makes sense to start with sagittal first and then progress towards the frontal plane eventually. Towards the end stage of rehab, we obviously want to think about sport specificity. So our patient is into trail running. That's probably the hardest thing she's going to do for her ankle moving forward, unless she takes up some other form of sport, right? And the thing about trail running is that you're usually running on an uneven surface like sand. There are roots. There's going to be leaves. There's going to be a lack of knowledge of what's under your foot from time to time. And you're probably going to have an increased risk of rolling your ankle for that reason. So for me, I want to prepare that ankle for all different types of surfaces, right? So by balancing on an RX pad, by doing calf raises on a slant board, trying to prepare the ankle for any sort of issue it may kind of face during the trail run, right? You also got to keep in mind during trail running, you go uphill and you go downhill. You need to prepare the foot, the ankle, the hip, all of the body basically for the forces of that sport, okay? The other piece I will say, and this happened for me recently because I did end up spraining my ankle and I did a really robust rehab program, right? I added a bunch of plyometrics into my program that hadn't been there in the past just so I could rehab my ankle. And I actually ended up with some pretty dang sore calves as well as some Achilles tendinopathy. So I have a history of Achilles pain on both Achilles. Normally, it's handled pretty well with some good exercise and being smart about my training. When I was trying to rehab my ankle, I ended up getting some Achilles tendon pain as a result. It was mostly because I was adding more plyos to try to get my ankle ready. Probably did a little too much. Gave me some Achilles tendonitis, excuse me. So from a mobility perspective, I like to perform some sort of mobility 7 times per week. This is largely because the research we have on stretching shows that if you do things more frequently, it tends to be more beneficial than doing it less frequently, right? And when it comes from a stretch perspective, it's not like you stretch so hard that you need a lot of recovery. So doing it on a regular basis every single day kind of fits the bill. And that's how I tend to like to approach my mobility for these folks, right? And we had just said the big heavy hitters that we're going to probably lack range of motion in the future are going to be dorsiflexion and plantar flexion. And I like to do a variety of different things to improve that range of motion. Early on, right after someone has an ankle sprain and is not tolerating a lot of range of motion, I like to do some soft tissue work, right? So we can work on, let's say, the calf musculature to improve dorsiflexion. We can work on the tib anterior to improve plantar flexion, right? From a dorsiflexion standpoint, I like to do a 3-way wall ankle mobility drill. So basically having your foot close to the wall, hands on the wall, keep the heel down, drive the knee towards the wall, drive the knee straight towards that second toe, Drive that knee straight towards the last toe, your pinky toe, and drive your toe towards the big toe as well, or drive the knee towards the big toe. I think that's what I said. Anyway, you're just mobilize the ankle into dorsiflexion in multiple angles. Okay. I also do like stretching. So just shooting in a few 60-second stretches as tolerated. Generally speaking, static stretching can be a little bit more provocative than, let's say, a dynamic stretch, like a three-way ankle mobility dorsiflexion drill. It tends to come a little bit later from a mobility prescription, excuse me. So largely when you start the evaluation and give your first mobility drills, I might not start with stretching, but suffice to say, if it's tolerated well, then you can go for it. And lastly, and probably my favorite mobilization, but they can be a little provocative in the beginning, is some sort of eccentric stretch or weighted stretch. And largely this could be just a calf raise, slowly descending to the very bottom of a calf raise. Let's say you're doing a calf raise on a steps, your heel is off the edge of the stair, dropping into full dorsiflexion range of motion, stretching for a second or two, and then come all the way back up to the top. So I use a combination of soft tissue mobility drills via knee to wall, ankle mobilization, static stretching, as well as weighted stretching or eccentrics. I do the same thing for plantar flexion. So we start with some soft tissue work. Usually have some foam rolling to the tib anterior. We also work on a dynamic stretch into ankle plantar flexion. So I like to do pretty much a child's pose position. So toes pointed, and then you sit your butt to your heels. So think about being in quadruped, hands and knees, sitting butt to heels with your toe pointed into plantar flexion. When your hips hit your ankles, it mobilizes you into more plantar flexion. So just like the three-way ankle dorsiflexion drill, we sink into that stretch and we back off, back and forth until you hit your desired amount of sets and reps, right? I also like doing some good old static stretching. So you can sit in a child's pose with your toes pointed straight back for a good 60 seconds. If you need more of a mobilization, you can always go into a low kneeling position. So think about going into quadruped, sitting your butt to your heels, and then kind of sitting upright with your hips on your ankles, stretching the ankles into plantar flexion more. And I also like using eccentrics or weighted stretches. So if you do a back to wall tib anterior raise, as you point your toes fully at the end range of motion, you're actually stretching into plantar flexion. So that's a great way to build back your plantar flexion range of motion. If you need more range of motion from an eccentric or weighted stretch perspective, just add a slant board. So do a back to wall tib anterior raise on a slant board, right? The slant facing down. So you have to go into more plantar flexion at end range of motion, right? And lastly, if you're trying to improve inversion and eversion, like I said, these typically aren't the ones that are quite as stiff. If anything, I think the eversion gets a little bit more stiff, which gets mobilized by doing your calf raise and lowers, trying to go into end range dorsiflexion. You get a little eversion with that. You can also try to mobilize into inversion or eversion just by using a heavy cable or heavy band. So when you're doing your resisted eversion, inversion, just get a little stretch at the end range of motion from the band, from the cable. I find that's really helpful for restoring that range. Okay, what is the treatment plan? What does the exercise plan actually look like? So I've given you a sample here. I apologize if you're listening to this and can't see this. At some point, I recommend going to YouTube or Spotify and check out the video of this so you can see what I'm talking about. But I'm basically giving you on the first week, when I first saw this patient, what is the program that I wrote her to do, right? So first and foremost, like I said, right after this injury, we want to move frequently at a low level, okay? So all these exercises are largely not aggressive, not intense, okay? They're nice and easy. So I prescribed a three-way ankle dorsiflexion versus the wall times 5 for direction. I just tell folks to push into where discomfort is felt. Don't push through a ton of pain. I give the same mobilization into plantar flexion and quadruped. So starting your hands and knees, sink your butt to your heels with the toes pointed into plantar flexion. Basically get a little bit of a stretch into plantar flexion. You're not hanging out there. We're just gently pushing into it and backing off again, okay? I like to do a seated pronation and supination. No weight, just a range of motion exercise for the ankle. Next, we do a seated ankle dorsiflexion, plantar flexion. So sitting on a table, sitting on a bench, heels down, pull the toes up, point the toes into basically a calf raise with just body weight. I like ankle circles, 10 per direction. We do band-resisted inversion, band-resisted eversion. I like to perform a simple double-legged calf raise with a pause at the top, a simple double raise, tib raise back to the wall, pausing at the top. And then I like to do some sort of single-legged balance with eyes open, 30 to 60 seconds. and then single leg balance with eyes closed for 30 to 60 seconds. And this was the exact program that I gave to my patient right after she had her ankle sprain injury. It was well tolerated. I took her through all the movements. She felt great while she was doing it. I actually made the ankle feel a little bit better afterwards. Okay. I'm used this program for about a week. And generally speaking, I like to try to progress my athletes as soon as they're ready for that next step. I'm not a big fan of giving them a program for too long. If they can tolerate something that's going to be a little bit more challenging, I'd rather push that sooner than later. I was seeing this patient in the beginning once per week. So next time I saw her, we just advanced. So now that I've gone through a case study and you see exactly how I like to treat lateral ankle sprains, you need to see the exact exercises I like to use to get these folks out of pain and back to their activities. I have a really good video for you. I'm going to leave a link in the corner. It's my favorite single leg balance exercises for folks after lateral ankle sprain injuries. Definitely go check it out. And lastly, I just want to say thank you so much for your support. If you're watching this on YouTube, please hit that thumbs up button. I'd love to hear your comments on how I like to rehab. Did I miss something major? Let me know. Disagree with me? Let me know, right? I love to hear it. And it also helps me out tremendously if you subscribe, right? Because you can see more videos like this, keep up to date with all the good stuff I'm putting out there. If you're watching the podcast version of this, please give me a 5-star review. A positive rating helps me out tremendously, allows me to continue making content like this in the future, 100% free for you. And if you want to go the extra step to really support the channel, consider subscribing to Fitness Pain-Free Insiders. It's a comprehensive educational resource and toolkit for the fitness and rehab professional. Think Netflix, but for trainers and physical therapists. It's premium content from yours truly, very similar to the podcast here. I've been updating this monthly for the past 5 years or so. I'm currently working on adding lots of courses, right? So not only are you getting more lessons, webinars, guides, you're getting complete courses in here. I've also recently added CEUs. So if you're a physical therapist or physical therapy assistant, you can get CEUs. And the best thing is it's only $1 to get started. After that, it's $25 per month, but you can cancel at any time, right? Get CEUs, $1, cheapest CEUs you can possibly get. All right. So if you want to learn more, I'm going to leave a link in the show notes. But otherwise, when you get started right away, go to fitnesspainfree.com, click on the programs link, click on Fitness Pain-Free Insiders online library to get started. If you want to see the references, there are a million of them. And I know you can't see them very well now, but I've left all the references in the show notes section. Check those out if you want to see the studies I included. Thank you guys and goodbye.